Welcome to seminar this week. We're going to go ahead and get started. Today I have the distinct pleasure of introducing our speaker, Dr. Bob G. Schultz. Dr. Schultz has an associate's degree from some no-name college somewhere in this country. He also has a PharmD from Regis University. Dr. Schultz is a Takeda Adherence and Health Economics Fellow here in the department. He is also in our PhD program. He has injured his head in a biking accident, so he may have post-concussion syndrome, so don't make the questions too challenging to Dr. Schultz. But today he's going to talk to us about an analysis he did that he will also be presenting at ACCP on Monday, which he just informed me of. So help me welcome Dr. Schultz.
Thank you for that awesome introduction, Todd. I really enjoy you telling everybody about my concussion. That's very, very nice of you.
Wait, is that PHI?
That is PHI. That's a HIPAA violation, sorry. But before we get started, thank you everybody for being here. Thank you for your attention during my presentation. I do want to make one announcement. We're only about a week away from Movember, which is Men's Health Awareness Month. And previously in pharmacy school, a lot of me and my friends and classmates, we grew out our mustaches during November to raise awareness for men's health. And then at the end of the semester, we had a little celebration with superlatives, best effort, best mustache, thickest mustache, those kinds of things. And then also had some fun facts about men's health awareness to really raise awareness about something that goes overlooked quite a bit. So November 1st, all the guys in here, girls, you can participate too if you really want to. We don't discriminate, but yeah, please join me in growing out your mustache during November. So like Todd said, I am giving this presentation on Monday in New York. It's going to be a 15-minute presentation there, so it's going to be a lot slimmed down version of this, but please be really liberal with your feedback because anything I can do to really improve the actual presentation is going to be well worth it. So the title of the research here is the cost effectiveness of a pharmacist-led medication therapy management program, specifically looking at hypertension management. And first, I want to thank all of the people who have helped me and made this possible to actually do this research. The folks over at the MTM clinic, Dr. Tilton, Dr. June, and Dr. Scott Horton, they've been really vital in helping me understand the operations over there, the costs over there, and then also have performed the literature search. And we created evidence tables for this, and it took a really long time to find the inputs for this, so I appreciate your guys' help on that. Anna Haltman, she's a P4, and she also helped with the literature review and organized the evidence tables as well. And then Danny Kwok, he was helping me a lot with the Excel spreadsheet. I wouldn't have been able to perform this analysis without your help, Danny. And then Dr. Touchette, my advisor, he was really crucial in conceptualizing this idea, conceptualizing the model, and then also just giving me some guidance throughout the entire research as well. So thank you guys. So during this presentation, first we're going to start with the MTM clinic, go over some of the clinical effectiveness there and how that's really going to inform the model. And then we're going to go over the methods of the model, how we built it, and then the inputs that we use to inform the model, which give us the results, and then finally the actual implications of the results from the model. The objective of the analysis is to investigate the 10-year cost effectiveness of a pharmacist-led comprehensive medication therapy management clinic compared with no clinic for primary prevention of stroke and cardiovascular disease in patients specifically with hypertension. And by the way, if you have any questions during the presentation, you don't have to wait until the end. If it's on the forefront of your brain, it'll provide some context while I'm going through it so I can answer it appropriately. So just to frame everything, heart disease is the costliest and deadliest condition in the United States and has been for a while. On the chart on the left here, you can see that it's about $109.4 billion per year that we spend on heart disease, which beats out things like mental disorders and diabetes and cancer. Those are more common kinds of things that we think about that are costly and deadly, but heart disease does go overlooked quite a bit. A lot of people suffer from heart disease, and we don't really have too much innovation in that space right now, right? We kind of look at rare diseases and orphan diseases and think that the drugs that we have for heart disease are good enough. but we just don't use them as well as we could be using them. So I'd like to point out the graph or the table here on the right, because most of the patients from the MTM clinic are over 65 years old, and most of the costs from heart disease come from those patients who are 65 years or older. And looks like there's about maybe 30 or 40 people in here, and about half of these people are going to have cardiovascular disease by 2035, as estimated by the American Heart Association. So it affects a lot of people in the United States. And I'd like to get a hold on it, and the MTM clinic is one great way to be able to do that. So most of you, I think, in here are pharmacists or have some pharmacy training, so you're probably aware of medication therapy management for people. But for people who aren't clinicians in the room, MTM is really a wide range of different services provided to patients that are designed to optimize therapeutic outcomes by helping those patients with their medications. And they can detect and prevent costly medication issues as well. So there's a lot of heterogeneity in how MTM clinic is provided. It really depends on the clinic that you're going to or the pharmacy that you're going to and who is actually providing that service. But all in all, it really comes down to a few basic core elements of MTM. And one of them, probably the biggest one, is medication reconciliation. So a patient will come in with a drug list or even a brown bag of all of their medication, and the pharmacist's duty is to really critically look at all of those medications, decide whether they're appropriate, if there's any drug-drug interactions, if the doses are appropriate, and make sure that their medication regimen really fits in with evidence-based guidelines. Same thing with disease management. If a patient comes in with diabetes, we should be able to look at their drug list and say, why aren't you on a statin? If their A1C is over 10, are they appropriate for insulin? Those kind of things where you're actually thinking about the disease and how we can best manage the disease as well. And we can follow and prescribe evidence-based guidelines. We can dispense evidence-based guidelines. However, it doesn't really matter if we're doing those things for evidence-based guidelines if the patients aren't taking their medication or aren't educated on how to take their medication properly. So the pharmacists in the MTM clinic also provide these things as well. With adherence, they give them pill boxes, reminders, and really kind of consult with the patient to see what kind of medication regimens will fit into their lifestyle, because if their medication regimen doesn't fit into their lifestyle, they're probably not going to take it. So that's another way that the MTM clinic actually addresses some things that can improve therapeutic outcomes. And then UI Health System is a very integrated system, and there's a lot of communication in between providers, so it provides a great opportunity for the pharmacist in the MTM clinic to be able to coordinate some of the care for the patients. So they're going to see their primary care providers, they're going to see their cardiologists and those things so they can get the appropriate care that they need. And then finally, there's a lot of literature out there that shows how MTM clinic can actually avoid adverse events and those types of things, because a lot of patients, they see multiple clinicians who are prescribing multiple different things. There's different interactions between those. And then also when the pharmacists are increasing or decreasing doses for the patient, we have to educate the patient on what kind of adverse events that they might be expecting. So it's a really great opportunity to educate the patient and monitor the patient for adverse events as well. So the UI Health Clinic here at UIC, it operates out of the Outpatient Care Center, and they employ 3 full-time pharmacists who are trained in motivational interviewing and then also in medication management. And the thing that really kind of makes it unique or differentiates them from a lot of other MTM clinic models is they provide a longitudinal pharmacist-led medication therapy service to where they're more hands-on approach with the patients, and they see the patients more frequently than some other MTM clinic models. And they offer these services to anybody who actually needs global medication or disease state management. And typically they'll meet with the patient for an hour for the initial visit to go over everything, and then they have 30-minute follow-up visits. And typically these patients come in about once a month. Sometimes they come in more frequent, sometimes they come in less frequent, but that's kind of about the average. And the Medicare Part D model, Medicare Part D actually recognizes some MTM clinics or pharmacies and reimburses them for the services that they provide. However, the model that they have is that the MTM clinic is allowed to give the patients 1 comprehensive medication review a year that they get reimbursed for, and then 4 other not in person, they can be over the phone medication reviews as well. So it's just quarterly, and there's not really a lot of a good relationship, I would say, between the pharmacists because they're not seeing the pharmacist as much during this. So this is kind of unique in that way, and the model would kind of have to change if we wanted to address some reimbursement issues. And if you're from UI Health, you probably know what the patient population is. A lot of African Americans and then a lot of Hispanics are serviced by the UI Health system, and that's not any different for the MTM clinic. The population is similar to that. So they actually published, and when I say they, the MTM clinic, and then also some folks from the PSOP department, they published a retrospective controlled cohort study that demonstrates the clinical effectiveness on hemoglobin A1C, diastolic and systolic blood pressure, and then emergency department and hospital admissions at 6 months and then a 12-month follow-up. And the demographics of the patients, they're about 70 years old and about 60% of them were female. And they did find a significant difference in systolic blood pressure reduction and then also a reduction of hemoglobin A1C. And those values are up here, 8.21 reduction in systolic blood pressure from baseline to follow-up, and then 0.63% from baseline to follow-up for those patients that were in the MTM clinic. So they also had this control group, right, that didn't actually go to the MTM clinic, and those patients actually experienced an increase in systolic blood pressure, about 1.5 increase in systolic blood pressure. So the absolute difference between the systolic blood pressure in the MTM clinic and the no MTM clinic was around 10. And what we did for this model, we have to have a no MTM clinic and an MTM clinic. And instead of using the no MTM clinic from the study that had an actual increase in systolic blood pressure, we used the patients from the MTM clinic at baseline. And the reason that we did that is because the baseline characteristics between the two groups were different. So, and also to control for previous medical history that we may not have had, we used patients at baseline and then patients at follow-up for the no MTM clinic and then the MTM clinic. So we start to develop our PCOTS question here. We have our population, those patients who are actually attending the MTM clinic. And the model was ran for 200 patients because that's about the average amount of patients that they have on a rolling basis. And then the intervention is the MTM service, comparator is no MTM service. And then we have, we need to think about our outcome because we have this clinical effectiveness from the actual MTM clinic of decreasing blood pressure, but we can't really relate a decrease in blood pressure to a decrease in cost or a decrease in quality of life, right? Those things are tied and related to cardiovascular disease and risk of stroke. So we had to come up with a way to actually translate that reduction in systolic blood pressure into a risk of stroke, myocardial infarction, and other. And the other encompasses transient ischemic attack, peripheral arterial disease, and then also an angina. And we'll get more in depth about how that was calculated in a couple slides. And then the terminal outcome, since it is a cost-effectiveness analysis, we have to have quality-adjusted life years and then costs, right? So we're going to be collecting life years lived, quality-adjusted life years, direct medical costs, and then the cost of the actual intervention, or the MTM costs. And we're going to look at this over a 10-year time horizon because, unfortunately, with the MTM clinic, when you're looking at the clinical effectiveness, you can't follow them for long enough to see, patients actually have these cardiovascular disease events. It happens over time. So we have to look at it from a 10-year time horizon to see how we can decrease the risk right now for the next 10 years. And then the setting is the outpatient care center. The perspective that we're going to be looking at, there's a lot of literature out there that looks at it from the provider perspective, which would be from the MTM clinic, looking at like the overhead costs, the cost of salary, and all of those kind of things for the clinic to provide that service. But that's not what we're looking at. We're looking at the payer perspective of how much insurance is going to reimburse the actual MTM clinic for the services that they provide and hope that it offsets medical costs down the road and look at the actual value of that to the insurance company. So we're going to look at the base case analysis, which the price for reimbursement rates, it's a little cloudy, but kind of the consensus out there that it's $1 to $3 per minute for MTM for Medicare Part D. And typically we go with a $2 per minute reimbursement rate for Medicare Part D. But we're going to look at a threshold analysis where we change the price and change the reimbursement for the MTM services. So we can look at how much the reimbursement would have to be to provide a value of $50,000 per quality adjusted life year gained, $100,000 per quality, and then $150,000 per quality. And there's a lot of discussion and debate about what threshold is actually appropriate to demonstrate value to insurance companies, but typically the $100,000 per quality gained is what we look at whether we decide whether something is cost effective or not cost effective. If it's under $100,000 per quality, we can in general say that it's cost effective. If it's over $100,000 per quality gain, there's more discussion that has to go on before insurances cover it a lot of times. In CVS Caremark, the PBM, they implemented a policy a couple of years ago where the plan sponsors were openly allowed to exclude anything that was above $100,000 per quality gain. So anything that is below $100,000 per quality gained is automatically covered and has to be covered according to the CVS Caremark plan. So we developed a Markov model to actually show the differences in costs and qualities between them while accounting for the different events that these patients are having. So we said that it was from the U.S. payer insurance company, and we said that it is a 10-year time horizon, and the cycle lengths are 1 year long. And we did that because there's actually really good evidence out there that shows how much costs are accrued in 1 year after having a heart attack or a stroke or one of these events, and the quality of life that is associated in that year of having a heart attack, stroke, or other event. So all of the patients, they begin in hypertension. In primary prevention, they have not had an actual event previously, and then based on the risk that we'll calculate from the Framingham risk equation, they'll be moving through this model. So the point of the actual MTM clinic is hopefully once we calculate the 10-year risk, that the MTM clinic is going to have a lower probability of moving to these events compared to the actual no MTM clinic. And that's how you're going to save money and cost offsets, and that's how you're going to increase quality of life, by keeping people in this actual hypertension state as opposed to moving to these. So based on the Framingham risk calculations that we have for each cohort, the MTM and the no MTM, they'll be moving to these other events here. And also, if they don't have an event, they just continue to stay in hypertension. But when you move over here, you can have a heart attack, and then you can have another heart attack the following year. You can have these recurrent events because we know that once you have a heart attack, the probability of having another heart attack that following year is increased compared to not having a heart attack previously. Same thing with stroke and same thing with other. And there's evidence to provide that. And then patients move through a tunnel state, moving to chronic CVD. And the reason that I built in these tunnel states is because it's not just such a quick change from having this heart attack and then all of a sudden you have chronic cardiovascular disease. It's more of you have a heart attack and you're accruing that hospital cost, maybe the ambulance cost going to the hospital. Now you have to follow up with your physician more, you have more medications, all of those things are relating to increased costs. And then the following year after that, you're beginning to recover. You're starting to regain some of your normal life aspects and those kind of things. You're still having more frequent physician visits than you would if you were just in hypertension, but it's not as much as that year right after you actually have a heart attack. So it's kind of like a gradual change from having an acute event and then you enter this tunnel state and then you move into this chronic CVD. And at any point when any patient is in these red Markov states, they can move into any of the other red Markov states as well. So if you have a stroke, you can move into myocardial infarction. And then if you have a myocardial infarction, you can move back to a stroke, and so on and so forth. And then at any point in time, a patient can die. That's just the reality of things, right? So each one of these Markov states has a probability of death. And obviously, there's going to be a higher probability of death if you've had an MI than if you've never had an MI before. So that's going to be a difference in how the MTM clinic is going to show decrease in cost and an increase in life years, hopefully. So the inputs that really inform this model, we have clinical inputs, we have utility inputs, and then we have cost inputs. And those clinical inputs are based on the MTM clinic's the clinical effectiveness. So we show that the MTM clinic group results in an 8.2 decrease in systolic blood pressure, and hopefully, theoretically, that's going to translate into a decreased risk of stroke and CVD risk, right? And then the other clinical inputs are gathered from the literature. The American Heart Association has a great statistical paper that they release every single year about probability of having a recurrent heart attack and all those kind of things. The utility inputs are the quality of life that is associated with each one of these states. So hypertension has a higher quality of life, which we'll get to. And then we have the quality of life for somebody who has a stroke, for somebody who has an MI and other, and then this chronic stable CVD state as well. And then the cost, like I was kind of alluding to earlier, is when you have a heart attack, you have that ambulance to the hospital, you have that hospitalization, you have that recatheterization, you have more frequent follow-up visits. Now you have to go to a cardiologist. Now you have new medications that you have to go to the pharmacy. So all of those are included in these actual mark-off states. These are the two equations that we use to estimate the 10-year risk for the patients. There's different for male and female, but the parameters that go into these models are our age, diabetes, smoking. So for smoking, we didn't actually capture smoking history, so we had to bootstrap smoking history into the patient cohort based on the regular distribution of patients who smoke and don't smoke. And then we have treated hypertension. Every single patient in the cohorts were treated for systolic blood pressure. Requirement was to have hypertension to be in this, and thank God they were all treated for hypertension. And then BMI is also a parameter in this model. So when we actually plug them into the model, the MTM cohort with the reduction in blood pressure comes out to have a 39.6 10-year risk for cardiovascular disease. And then the no MTM cohort has a 42.8 risk for 10-year risk of cardiovascular disease. So when I did this, I looked at it and I was like, that's not that big of a difference. That's only like 3.2%. How are we going to show cost effectiveness of the actual MTM model since there's such a small difference? But we'll get into that once we take a look at the actual results. So the Framingham risk equation gives you a 10-year risk, but our cycles are only 1 year long, right? So we had to transform this 10-year risk down into a 1-year risk so it matched up with our actual cycle length. So the way that you do that is you take a probability and you transform it into a rate, and then you transform that rate back into an actual probability of 1 year. So when we did that with those risks that you saw on that previous screen, there's a 1.1% chance of having a stroke, 1.1% probability of having an MI, and 2.7% probability of having an other. Very small. And the differences between the MTM and the no MTM is just 0.1% for stroke and MI, and then only 0.2% for other. And then if they don't have one of those events, then they go back into primary prevention where they don't have an actual event and they just stay in that hypertension state. So in the MTM clinic, it was 95.1%, and then the no MTM clinic is 94.7%. So again, I'm looking at this like there's not that much of a difference, probably not going to be that big of a difference. And then the dark gray boxes here are the chances of having a recurrent stroke. So if you have hypertension, you have a stroke, and then the probability that you actually have a stroke the following year. And that's the same for both the MTM and no MTM cohorts, because there's just not evidence out there that supports that if you go to an MTM clinic, your risk of having a recurrent stroke that following year if you had a stroke previously is lower, right? So we just had to assume that they're the same, and I think that's a fair assumption. So there's 99 inputs into this model, so there's a lot more that goes into this than just these things here, but these are kind of the big ones that really drive the model forward and show the difference between the two cohorts. So then we also had to find the quality of life estimates, the utilities for these different states, right? So for those of you who are not familiar with quality adjusted life years, 1 is perfect health, and then 0 is death. So not pictured here is death, but death is just 0. So as you can see, you have higher quality of life for hypertension as compared to these other types of events that you have. And this kind of goes back to that tunnel state that we built in, because you can see somebody has stroke and they have that real decrement in their quality of life. And then that following year, they're beginning to recover from that. And then finally, they go into this more stable state of quality of life. So that's kind of how it was built. And there's also, these can go back and forth, but just it makes everything complex and a little bit crazy when you build a web. But these patients can go over to stroke, and those patients can go over here. That's not really shown in this diagram here, but just think about that anybody that are in these states that have the dotted lines can basically go anywhere within that web during that entire 10-year cycle length, or 10-year time horizon. And then we collected the actual inputs for the cost of the cost effectiveness model. So as you can see, just having hypertension is not that expensive. You just have maybe your doctor visit once a year or something, and the medications that you're on for hypertension. But then once you actually have these events, you know, $40,000 for a stroke for that entire year. That includes the hospitalization and everything that we've talked about. $50,000 for myocardial infarction, and then right around $25,000 for other. And then you move to that tunnel state. You don't have that really acute lengthened hospitalization. You may have one hospitalization or something, but the costs are lower for that tunnel state than they are for that year that you actually had the event, and so on and so forth. And then history of cardiovascular disease is lower than those tunnel states as well. And then the cost of the MTM clinic, the $626 per year, that equates to that $120 initial visit and then $60 follow-up visits, because it was $2 for the initial visit per minute at 60 minutes, and then 30 minutes for all of the follow-up visits. So that's what that equates to. And all of these are per patient per year. So we finally get to the actual results. Over 10 years and a cohort of 200 patients, it costed about $1.4 million, the insurance company, to the actual MTM clinic, which kind of seems like a lot. You don't think that an MTM clinic is getting that much, but that's over 10 years, and that's for a cohort of 200 patients. So it did cost the insurance company a significant amount of money. However, it did offset about $500,000, a little over $500,000 in medical costs, and increased those patients' quality of life by 18 QALYs, and increased the total life years by about 4.5. It doesn't seem like too much, but again, it's not necessarily extending your life a ton, but it's really preventing those patients from going in that cascade of cardiovascular disease where your quality of life is really impacted by having those kind of events. And it avoided 10 events compared to the two different cohorts. So that equates to a base case cost per quality gain in ICER of about $47,000, $48,000. So that would be considered very cost effective in today's world to an insurance company at that current reimbursement rate. And remember, that's a monthly reimbursement rate, not the quarterly reimbursement rate for Medicare Part D. So if this was reimbursed by Medicare Part D, the ICER would be way lower than and way more cost effective than that. But we don't know if the clinical efficacy or the effectiveness is the same for somebody who's going 4 times a year as opposed to every single month. The cost per life year gained is right under $200,000, and then the cost per CVD event avoided is about $84,000. And my initial instinct was to compare this $84,000 of cost per CVD event avoided to the cost of actually having those events, which we look back, it was like $40,000 or $50,000 for a stroke or an MI and $25,000 for the other. But then I realized that it's not just that 1 year that they're having, they're accruing all of those costs after they actually have that one CVD event that are downstream of that in the tunnels and then also in the chronic stable that would make that $84,000 per event avoided probably a good deal for the insurance company. So then we did the threshold analysis, and the base case was right around $50,000, right? So there wasn't too much changing the price in that. We just increased the follow-up visits by $2, and that gave us the $50,000 per quality gained threshold, an increase of about 3% in the reimbursement rates. But then when we looked at the actual $100,000 per quality gained, which is kind of that standard, that would equate to about $200 for an initial visit and $100 for each follow-up visit. So a huge difference, right? So 70% increase in those actual reimbursement rates. And then the $150,000 per quality gain increased it up to $280 for the initial and $140 for the follow-up visits, with almost 140% increase in the reimbursement rates. And when I saw these, I thought that, I know this is a buzzword coming up, Chris, but this might be a great prospect for like a Netflix-style model, to where the insurance company pays the MTM clinic basically per patient annually. So like this, you see in the middle there, the annual cost per patient per year. You know, the insurance company or the MTM clinic could go to the insurance company and say, give us $1,000 per year and we'll take care of your patients. And they'll have unlimited visits. It gets tricky when you say, oh, maybe we should just do this monthly follow-up and whatnot, because these patients, they're coming maybe every 3 weeks. So if they came in a 3-week interval, then there would be a firewall and they wouldn't have insurance coverage and the MTM clinic wouldn't get reimbursed, right? Because you can't refill your medications earlier, you can't get services early. So this model, the way that it's set up, might be a great prospect for like a Netflix style model, where they just pay $1,000 per patient, and then the patient can go to the MTM clinic, receive that clinical benefit, receive those health benefits downstream, and it works out. It makes it easier for the insurance company, and it makes it really good for the actual MTM clinic, because they're getting reimbursed for the services at the value that they should be. And it works out for the patient too, because then they can have a better relationship with their actual, you know, pharmacist providers. So with any model, whenever you're forecasting something, especially over 10 years, there's going to be a lot of uncertainty, right? So the way that we address those different uncertainties with all of those inputs is by running sensitivity analysis. So we have one actual input for the cost of a heart attack, right? Or one input for the cost of a stroke, but that may be different in the Southwest than it is in the Northeast, that it is in the Midwest. You know, every single hospital, every single insurance company is a little bit different. So the way that we address that is with a probabilistic sensitivity analysis. What a probabilistic sensitivity analysis does is it takes all 99 of those inputs and it places a distribution and parameters over each one of those inputs, and then varies them all at the same time while outputting 10,000 different simulations of patients running through the model. So we get 10,000 different ICERs, and we can say whether, you know, varying all these things still makes it cost effective or not cost effective anymore. And then going back to that willingness to pay, you know, if somebody is not willing to pay for any health benefit, why would they pay for any intervention, right? Like if this extends my life by 3 years or the quality of my life by a bunch, but I'm not willing to pay, it's not going to be cost effective. So that's why when you look at this graph, the blue is the MTM clinic. If somebody's not willing to pay for any type of health benefit, then it's not going to be cost effective. But as somebody is more and more and more willing to pay for a health benefit, you see it become more and more and more cost effective, right? So right at that $50,000 threshold of I'm willing to pay $50,000 for each quality that I gain from this intervention, it's right about a coin flip, whether it's cost effective or not. But then once you start to reach the common thresholds that we see at insurance companies now, you're almost, you know, reaching that asymptotic value. You're right around 97% cost effective. So if you have this commonly cited willingness to pay threshold, then it's almost a guarantee. Guarantee is a strong word, but it's almost a guarantee that this is going to be cost effective. So another thing that we do to look at the different parameters in the model is we vary them just one at a time and see how they're actually affecting the results. So as you can see at the top here, this is the ones at the top have the highest impact on them, and these are the different ICERs that they would go to. So for example, the probability of going from hypertension to death. If we use the bottom of the range that we have for that parameter, the ICER for the base case goes up to about 90,000. So this is a really good identifier of, you go back and you look at these parameters and say, do I have good values for these parameters? Because you want to have good really good and strong parameters for these values because they make a big impact on the results. So when I went back to look at the hypertension to death parameter that we have, it comes from the CDC's national value statistics of like the actual mortality rates for the population based on these cohorts, sex and age. So it's a pretty solid stat. And also I looked at the range that we're actually varying them for, and the blue is when you decrease that range. So the actual mortality rate for these patients is 1.8%. But then when you decrease it to 0.0004%, then it goes way over here. And that's exactly what it did. The low range value for the hypertension to death for the mortality rate for the general population was actually very low. It went to like 0.0004% mortality rate. So that doesn't make sense. So this is kind of a parameter that's really driving it, but it would actually, making it more realistic would actually make this a little bit tighter. But as you can see, none of the parameters actually go over this $100,000 per quality threshold. Some of the other things that were important that drive the model is hypertension to other. If you remember, there was a higher probability of patients going from hypertension to other than there was from hypertension to MI or hypertension to stroke. So that'll have a big impact on the model when you vary that. And then the utility for hypertension was a big driver in the model too, because a lot of the patients were staying in that hypertension state. Remember, like right around 95%, each cycle those patients are staying in that, so that has a large impact on the model as well. So with any kind of model when you're forecasting, you have to make some assumptions, and this was no different. So patients entering the model have no prior history of stroke or cardiovascular disease. Unfortunately, we didn't have a comprehensive medical history for these patients, and we couldn't actually tell if some of the patients had a previous stroke or a previous MI before. And the Framingham risk equation is only designed to predict risk for patients who have not had them before. However, I'm not too worried about this because these patients are the same, right? It's just before the actual benefit of the MTM clinic and then after the benefit of the MTM clinic. So there was no differential medical history differences. We can assume that they were the same. And also, if some of those patients did have a prior history of cardiovascular disease or stroke, that would only increase the risk for having a subsequent one. And we know that once you start to increase these things, you see a larger separation between the two groups. So I'm not too worried about that one. The patient's risk for an event is homogeneous within each cohort. And this is just kind of one of the properties of a Markov model. So we had our patients from the retrospective cohort study that informed the clinical effectiveness of this. And each patient has a different risk, right? Every patient is individual. They have a different risk of actually having an event or something. But however, in order to run them through a model, we had to aggregate all of them and come up with averages for all of them. So basically, the entire cohort of MTM, the entire cohort of no MTM, they all have the same risk of moving through the model. And then the chronic CVD management incurs the same cost and utility independent of what they had previously. So that Markov state of stable cardiovascular disease history, that was just one state, and all of the patients funneled into that 2 years after they've had an event, if they don't continue to have recurrent ones. So it may be different, you know, long-term, 2 or 3 or 4 years down the road, a person with a stroke or a person with an MI or a person with other, they may have different quality of life. They may incur different costs further down the road. But that would have required to build a lot of memory into the model and would have increased the complexity in not so good of a way if we really wanted to get that granular with anything. So after a patient has an event, the probability of having an event of a different kind is the same probability of having the event in primary prevention. So let's say that moving from hypertension to having an MI was 1.1%, right? So if a patient has hypertension, they move into a stroke, the following year, their probability of having an MI is 1.1%. It's the same as moving from hypertension to MI as moving from stroke to MI. There wasn't really good evidence to support, you know, if there's a increase of having an MI if they've had a stroke before, or having a MI if they've had peripheral artery disease. We would have had probabilities for all these different scenarios, moving to different scenarios, and the evidence just isn't there to support that. So that's something that we had to assume. Patients who have an event of the same probability, regardless of whether they receive the MTM or not. I've already talked about this. That recurrent event of having a stroke is 11.1% in the MTM group and the no MTM group because we don't have evidence showing anything different than that. Patients who have multiple events of the same have the same mortality rate of those that have their first event. So if your mortality rate of having a heart attack is 10%, and then you have another heart attack that following year, your mortality rate is still 10%. So it's probably likely that your mortality rate increases the amount of events that you actually have. But again, that would have required to build in a lot of memory and complexity into the model. So we wanted to keep it parsimonious. So the limitations of the model is the Framingham risk equation. Anytime you have to extrapolate some estimates or predictions over a long period of time, there's a lot of uncertainty that goes into that. And one of the things was a smoking history that we didn't have. We also didn't have that comprehensive medical history that we were talking about. And then the Framingham risk equation, it is based off predominantly white population, which doesn't fit our population, right? The Framingham group, they have included patients, pools of patients that are African-American to kind of diversify this. However, it is still largely based off of white population. The other limitations is the generalizability of this study. Like I was saying, there's a lot of heterogeneity in how MTM clinic services are delivered. So in order to use this kind of research to negotiate different reimbursement rates, an MTM clinic would have to show similar clinical efficacy. And each MTM clinic has different populations as well. So it's tough to say whether these clinical inputs are actually generalizable and then the actual outcomes are generalizable as well. So we already talked about the mortality probabilities for patients that have multiple events. And then finally, patients in the chronic CVD state, they may have differential costs, if they've had a MI previously or a stroke previously. So what's the pull-through? The North Star is the patient, but what's the pull-through? So the MTM clinic, it provides significantly impactful long-term health benefit to the underserved Chicago community, and that's not really arguable. They allow any patient to come to their door and to receive benefits for their services, and we can show that through this analysis. So the reimbursements for MTM under Medicare Part D are inadequate to cover the comprehensive and frequent services provided by pharmacists, right? They only reimburse 4 times a year. That's not enough for a clinic to actually operate and invest money into their pharmacists to be able to serve patients like this. It's not going to work how it's set up right now. So this analysis provides evidence for reimbursement reform applicable to MTM clinics that can demonstrate similar clinical effectiveness, right? So if you have an MTM clinic and they reference this when they're talking to a payer, the payer is going to say, but is your clinic like this? Like, do they actually have the same patient population? Do they decrease blood pressure by this much? But it provides an opportunity for MTM clinics to actually make their research more robust and demonstrate these kind of things so then they can use similar things like this. So the MTM clinic demonstrates significant value in hypertension management by avoiding stroke and cardiovascular events. While it does cost the payer over $100,000 per year, they do provide that important direct medical cost offsets and the significant improvements in quality of life. So this is a big one, and I've been biting my tongue. In addition to hypertension management, the MTM pharmacists, they provide other services of value, right? They provide diabetes management. We saw the reduction in A1C. That was not a part of this risk, basically. It was yes or no question where they have diabetes, but reduction in A1C would significantly decrease the risk of having a cardiovascular event as well, right? Adverse event avoiding and management, addressing adherence and care coordination, those are all huge parts that are going to provide a huge health benefit, but those are not included in the Framingham risk equation, right? So this is just specifically looking at hypertension management, just one little piece of the puzzle that MTM clinic provides, and it's cost effective. Just one little piece of the puzzle is cost effective. So imagine quantifying those other types of value and including it into this. it would, the cost effectiveness would be much, much larger. So this is just kind of like a starting point, a baseline, and it's still very cost effective. So this underestimates the value of the actual pharmacists. And then lastly, this is really what I would really love to see this research actually make happen in the future is that if we allow for insurance companies or if we allow for these MTM clinics to negotiate higher reimbursement rates, then the MTM clinics can get more compensation, right? And they can hire more pharmacists, they can expand their clinical services. And we know that pharmacists provide this excellent value, this excellent service, but it's just, they don't have the required reimbursement rates to actually expand those clinical services. There's a lot of pharmacists out there that are looking for work that want to really apply their clinical knowledge, but they're kind of stuck in doing a lot of things that, you know, maybe menial tasks because they can't get paid for the actual clinical services that they actually provide. So I'm hoping that this really changes that, or at least starts to push the needle a little bit and actually getting pharmacists reimbursement for the actual services they provide. And that's it. Questions?
Great presentation. I have a question about Framingham risk. You said majority was derived from majority white population.
Mm-hmm.
So how do you think that would sort of impact your findings? I don't know what the majority population is at the EPM. I think it's African American and Hispanic.
Yeah.
Which likely have a higher risk of.
Yeah.
Relative to that, to the white population.
Yeah, it's a great question. Thank you for asking that, Chris. Seriously, this is a good question. So yeah, I think you're right. The African Americans and Hispanics would have a increased risk. And like I said, the Framingham has tried to address this because this has been a problem previously. So they tried to like put African American and Hispanics into this, you know, logistic regression equation where they're getting these beta coefficients. So it more reflects the general population. However, yes, I think it would increase the risk. I think this patient population has an increased risk compared to what this actually gave us. And how that would impact the results, as I was kind of saying earlier, when the risk increases, you see a greater separation between the two groups. So if there's actually an increased risk, we're going to see a increased cost effectiveness and lower ICER, but a higher value for this patient population. So I think they would actually lower the ICER if we had better estimates for the patient population that we're actually looking at. Thank you. Mm-hmm. Mm-hmm. Yeah, I think that's probably the biggest limitation, to be honest, because ideally I wanted to use that published study that looks at the MTM clinic and no MTM clinic, right? However, like the baseline systolic blood pressure was different. So it was almost kind of like regression to the mean, where you had people who had a higher systolic blood pressure. They had a huge 8.21 reduction in it. And then the patients who didn't enroll in the MTM clinic, they saw an increase in actual systolic blood pressure. But then when I was thinking about this, and the reality of it is those patients who didn't enroll in the MTM clinic for this study, they're probably, maybe they don't have time, or they don't care about their health as much as the other people. The other people who enrolled in the MTM clinic are willing to you know, do something, you know, to change their behavior in order to make a difference because they want to make a health benefit in their life. And I think that's actually the population that goes into MTM clinics, right? You don't see people receiving MTM services who don't want them. You know what I mean? So the only people that are actually going to receive the MTM services are the people who want it. So I actually think that even though it is a limitation, I think that the estimates that we use actually reflect a realistic population, but there's no real evidence that would be able to support that.
Thanks, Bob.
Thank you, everyone.